फुल स्क्रीन
है
किधर ये हाँ Good morning, students. Today we will be considering the okay. So today we will be considering the revision of the questions of regarding 2014. Okay, let's start. There were a number of questions. All of them has got their clinical significance from the theory point of view as well as for practice and your practical life, where you are getting a lot of questions regarding the same criteria. The questions asked are mainly related to burn, related to ischemia of the lower limb and the gastric outlet obstruction and testicular tumors. The two questions regarding gallstone and CA breast we have already covered. So the major question is describe in detail assessment, fluid resuscitation and management of a burn patient. This covers all aspects of a burn management. So to understand what is burn, burns itself is a major catastrophe and carries a very high mortality whenever related to higher degree and depth of burns. Whenever burn patient comes to you, there are certain criteria which patient has to be admitted and which patient has to be treated on outpatient basis. The criteria are admission of burn patient depends on total body surface area. This is TBSA. Just understand what is TBSA 1%. It is 1 to 3%. 1% stand for what? How do you calculate 1%? It is called as a palm rule. And what is a palm? This palm of the hand. This much area of the hand of an individual is considered as a palm rule, 1% of a total body surface area. And remember, this is always related to the age, height of patient and infant, children and adult. This changes, the area changes. So, if it is a 10% total body surface area, whenever we use the word TBSA, please understand this contains superficial burns, deep burns and partial thickness burns. Otherwise, we will be specifying. So 10% of partial thickness and full thickness burns. Totaling 10% of TBSA. Superficial burns here we are not including. Under 10 years of age. All other age groups, partial or full thickness burns more than 20%. Pure full thickness more than 5%, irrelated of the age group. And any burn, face, hands, genitalia, perineum and neural joints. And most important, electrical burns. This type of patients, this percentage of burns need admission in the hospital. Okay. So how do you assess? There are certain rules of assessment of a burn patient. There are number of charts available like Lund and Border chart for larger burns and Berklow formula for percentage into children, because children it differs slightly. But for all practical purposes, what we are following is called as a Wallace rule of 9, and this is sufficient for all practical management of a patient. What the rule says? Each upper limb 9% of a TBSA, each lower limb 18%, anterior trunk 18%, posterior trunk 18%, head and neck 9% and perineum 1%. Even if 1% perineum, this is considered as a severe grade and patient need admission because of complications. There are certain changes in children. In children what happens? Head and neck contains a large area which accounts for 18 to 21%. If you see here, it is exactly the double of an adult. Okay, so this is how we go for percentage, and this graph or this chart from Love and Bailey gives everything in detail. Right side figure shows you where actually burns are counted. Chest, front and back, 9 plus 9. Abdomen, 9 plus 9, back and front. Right leg, 9 plus 9, that means up to knee joint, below knee joint. Left leg, 9 plus 9. And both arms in total 8 to 8, 9 to 9, and face 9%. Total it comes to 100. Here you see in children, the area of face has increased and area of leg has decreased. As against that, in infant, the head and neck area is more. It is 20%. Similarly, abdomen and chest are more. Lower limb are more. Upper limb are more. See, so that is how it has got a comparatively higher percentage. And that increases the relative mortality also. In children, the lower limb considered less, 20%. Upper limb, 20%. Everything is taken by the head and neck. So this is how you have to calculate the percentage of burns according to Wallace rule of 9, which is in existence since 1951 and doing well. Okay. Apart from percentage, it is a degree of burn. This carries a major importance on the prognosis and management part. There are sometimes you call 3 degrees, sometimes you call 4 degrees. First degree involvement up to the epidermis. Second degree involves epidermis and some part of dermis. So we call it also partial thickness burn. This partial is divided into A and B. A stands for superficial second degree or superficial partial thickness. What it involves? Upper part of the dermis. Deep second degree or deep partial thickness extends up to a reticular layer of dermis. You can see on the figure where it is extending. And below that, whenever you go for full thickness of dermis, involvement of dermis is indicative of a third degree or full thickness burns. And sometimes we call fourth degree, what it is? Involvement of fat. You get the difference? Epidermis, partial dermis, superficial and second degree, first second degree. Third degree, it is the involvement of dermis. And fourth degree, involvement of subcutaneous fat and associated deep structures like bone and nerves. Okay, this is how we classify. Afterwards, we will consider it in detail. So what it depends on? How do they depend? Mainly they depend on a type of burn and the causative agent of burn. In history, you must always ask why he has suffered burn. Remember one thing, most of the suicidal, accidental and homicidal burns. Homicidal and suicidal are usually very deep. Comparatively, accidental burns may be superficial. Because in homicide and suicide, there is an intentional attempt. It is an intention which is more important in cases of burns. So what it depends? First, how long patient is burned, duration, the temperature of the agent and the which material is causing burn. Okay. So this is for general knowledge. Burning of skin at 45 degrees, 44 degrees. It takes 6 hours for irreversible damage. Frankly speaking, nobody will put a hand for 6 hours. That means anything below 44 degrees is likely to cause more of a reversible damage. The moment you go to 70 degrees, where skin takes only 1 second for epidermal destruction. Only 25 degrees difference and see the severity. That means severity of burn straightway increases considering the degrees in Celsius. Causes of burn of death. Cause scald. Scalds are boiling water. Very common in home accidents in the home. Fortunately, they are usually superficial burns. Fat burns means whenever the burns has occurred due to pouring of oil, which is also common in our kitchen. Here oil causes deep dermal burn. Flame burn, usually accidental, they can be mixed deep or full thickness. Again a common burn of acid and alkali. Alkali burns are usually deep dermis and full thickness. That means alkali burns are better than acid burn because acids are of two types. Weak acid, superficial, strong acid, deep dermal. Electrical burns for that matter, all of them are full thickness burns. We will consider electrical burns in separate as we go by our lecture. Okay. So what is the pathophysiology? How does the burn affect the whole body process? Because now it is not that part which is involved, which is burn. It is the affectment of all the organs of the body which are due to the toxins released. So this is called as a pathophysiology. What happens? Significant burns are associated with a release of inflammatory mediators from the wound itself and other dead tissues. They in turn produce vasoconstriction and vasodilation and increasing the permeability, and because of permeability there is a local or generalized edema which itself is more pathological. The immune system is depressed. The catabolic hormones, it is a hypermetabolic state. The burn is a hypermetabolic state. Remember, all burns lose weight after second day. Up to 48 hours because of edema, weight is more. After that, it is a weight reduction. And the defense mechanism of a stomach is also affected because of a mucosal permeability, which leads to curling ulcers. Curling ulcers are ulcers which are found after burn patient. So, in severe burns, pathophysiology is vascular permeability, immunosuppression, decreased renal blood flow. Decreased renal blood flow occurs and it is oliguria. Altered hemodynamic circulation, hypermetabolism, and increased gut mucosal permeability, which is going to cause the edema and also ulcers. Okay. So, pathophysiology and area of a cutaneous injury. How the area of burn is distributed? There are three zones. The zones of a burn region. The centralmost is called as zone of coagulation. Around its periphery, zone of stasis. The third zone is zone of hyperemia. What is zone of coagulation? It is a necrotic area of burns where cells are disrupted, and this area of coagulation is irreversibly damaged. This is the center of an earthquake. Next is stasis. It is surrounding area to the necrotic zone. It is moderate insult and patient can survive the coagulative necrosis. Here what happens? Vascular leakage occurs. The third is hyperemia. It is away from the center. It is vasodilation because of inflammatory surroundings, and this usually where the healing of the burn starts, and there are less chances of further necrosis in this area. Okay, so what are the grades? There are two types of differentiation. We will consider first degree. No blisters, blanching on touch, painful, heal without scarring in 5 to 10 days. So you must be able to differentiate first degree burns from others, where you can give confidence to the patient and patient can be treated as outpatient. Okay. Then comes the second degree. Here differentiation from first degree to second degree is most essential. Management absolutely changes. What is second degree superficial? It is a superficial partial thickness burns, where by definition it extends only to superficial or papillary dermis. This you keep in your mind. Upper part of the dermis, second degree, superficial. Deeper part of the dermis, second degree, deep partial. Okay. In first part, blisters are always found. Blister formation is a type of defense. Nothing to be afraid of. Blisters do increase in size or new formed up to 48 hours. What is more important? The underlying dermis is pink and moist, and fortunately these patients heal without scarring and treatment is non-surgical. What do you see on examination? most important is capillary return. It is blanching on pressure. The blood supply returns after pressure. And pinprick sensation. Never forget this test. Pinprick sensation is normal. Always have a sterile needle to sense or to examine the pinprick sensation. Second degree, deep partial. Here what is happening? Blisters are seen, but the skin below is mottled. In superficial, it is pink and moist. Here it is pink and white color because the blood supply is varying and the dermis underlying is not moist. You will immediately feel the difference that something is wrong. It is a deep dermis. It is a deep burns, deep second degree burns. See the major difference. In first part, healing is non-surgical without scarring. Here, the simple dermis involvement, it is healing with scar. So this scar will take 3 to 5 weeks for healing, but it can heal without surgery. But unfortunately, this scarring is hypertrophic scarring. See what is happening, the prognosis. On examination, dermis appears pale and mottled. It does not blanch, but it is painful to the pinprick. Patient is unable to differentiate between a blunt pressure and a pinprick pressure. If do this simple test, you will find out what is the prognosis. Okay. And third degree, also called as a full thickness. What is this? Total dermis is involved and there is a formation of eschar. Eschar means dead tissue. It is black or brown, painless, and there is no bleeding or no pain even on deep piercing by needle. So needle has given us an idea whether it is a superficial second degree, deep second degree or third degree. A simple needle test. Okay. This is a different classification of 4 degrees. Same thing, put it other words. This is also involvement of depth. Same, but just read it carefully. There are no blister formation in first degree. There is erythematous or the vasodilation, and it is very painful condition. Patient complained of a severe pain in first degree and second degree superficial. Okay. First degree healing occurs without scarring in 5 to 10 days. Second degree partial thickness or full thickness. Here involvement of upper layer and it is healing within 7 to 14 days. This deep second degree healing in 3 to 9 weeks with scar. Third degree full thickness involvement of all the layers. All dermal and epidermal components are lost. And unfortunately, this burn heals by contracture. And this requires a surgical management like excision and skin grafting for healing. And fourth degree is something more than that. Beneath the skin, it involves the organ. Even muscle, bone and brain also can be involved in burn patient. If you deep scalp burns, the brain is also burned. Okay. So this is the 4 degrees. That is a 3 degrees, 4 degrees. No major difference. How do you manage? Simple principle. First aid is most important, and what is done there? Stop the burning process. Because unless the process is stopped, the patient cannot be improved. And keep the patient away from the burning area. These are the primary management. Cooling with tap water. No ice cold water. Remember, it is a room temperature tap water by continuous irrigation for 20 minutes. Because cold water can cause hypothermia and hypothermia itself is detrimental to burns. Okay, so this is a cooling tap water. Then what? You have to decide whether the patient needs admission on burn unit. This is what we have described. Initial management also, remove the cloths of the patient. Why? Because the cloth themselves may act as a tourniquet. It looks simple, but it is very serious. You have to cut the burn cloths and keep them for a medico-legal evidence. Clean the dust and mud. Antibiotic, tetanus toxide, and local antiseptic. And then you have to cover the dressing. What is the covering important? It gives a comfort to the patient and sedation. This is the primary management. Then comes the major fluid resuscitation formulas. Commonest formulas we are commonly using today also is a Parkland formula. What Parkland formula says? In old version, total body surface area TBSA percent multiplied by weight multiplied by 4. This is the amount of volume needed in 24 hours. What they are doing? Half of this volume. Half is given in first 8 hours and rest half is within 16 hours. Here mainstay is crystalloids only, and the preferred crystalloid is Ringer lactate in first 24 hours according to Parkland formula. Second formula which we don't commonly follow is a Moore and Barclay formula. Here most common colloid. You must know the difference between crystalloid and colloid. It is a colloid based formula, but usually colloids are given commonly after 24 hours. So what is the formula? 0.5 multiplied by percentage of body surface plus multiplied by weight is 1 portion. 0.5 percentage of burnt area and weight. This will make 1 portion. 1 portion of the colloid formula. And this 1 portion will be given like 4 portion, 4, 6 and 12 hours. 4 portion in first hour, 4 in second, 4 in third, 4th in fifth and 5th after 12 hours. So here what we are giving in 8 hours are given by 4, 6 and 12. This is the duration of a management of a Moore formula, and 1 portion is given in each period. This is what is done. And for children they call it as a Galveston formula, where 5000 ml is given on TBSA burn in meter square. Totally 5000 ml is given, plus 5000 per meter square in first 24 hours. Because what they say, children need more fluids according to the Galveston formula, not commonly followed. Brook formula uses both crystalloid and colloid. But the key here is a maintenance or monitoring of the urine output. What it is? It should be between 0.1 to 1 ml per kg per weight per hour. 1.5 is ideal. Below 0.5, patient goes for anuria. Okay. If output is below this, you have to increase what? You have to increase the infusion rate. So these are the different formulas. So this is the chart. If you remember, you can write down everything regarding burns, management of burns. So what it says? Immediate care and follow-up care. We are talking of a local. Sedation, analgesics, antibiotics, fluid resuscitation and hysterectomy. This is important for all third-degree burns. Hysterectomy is equally important. Follow-up, dressing, wound cover, and late care. After 3 weeks, it is a skin grafting, and after long time, it is a contracture release. This is a surgical management. So, what are the fluids used? If possible, use oral fluids. If you are giving oral fluids, always there has to be salt. Even the formula for rehydration is also useful for that. So the salt must be added to the fluid. Monitoring of urine output is the key. Fluid are calculated by standard formula. Children below above 10%, adult above 15% need IV fluids. Crystalloid like Ringer lactate are most common. Why important? They are effective to maintain the intravascular volume. We are only maintaining the volume. Okay, remember this. They are less expensive and they can save capillary leak. Ideal fluid is crystalloid. There are three types of fluids. Crystalloid is Ringer lactate and Hartmann solution. Colloid is human albumin or fresh frozen plasma FFP. Hypertonic saline sometimes used. It produces hyperosmolarity and hypernatremia. The use is less edema and less chances of stereotomy. There will be less edema but not commonly used. What are the colloids? Plasma proteins. The function is maintaining capillary hydrostatic pressure. Usually these proteins are given after 24 hours because in first 24 hours there is a massive fluid shift and it causes protein leak. Permeability is more common in first 24 hours. So colloid preferably after 24 hours. And then comes the definitive treatment. Admit the patient, intubation, accessing the percentage, degree and type of burns, whether to keep the patient is patient burn unit, fluid residue formula like Parkland, and now the change has occurred. Maximum percentage considered is 50%. I will give you this in the end of it. Half of the solution first hours, rest is 16 hours, and there are different formulas. Local management, there are two basic types of management: open management of burns and closed management. For a minimum say 20 to 30%, we can think of a closed method of dressing. But large areas 50, 60%, 80%, open method is a treatment of choice. All full thickness burns, tangential excision of burn with or without skin grafting is one of the method. And within 48 hours that excision has to be done. Exposure treatment for head and neck. Cleaning with providine iodine. Local application silver nitrate sulfomelon. Wound coverage has to be given whenever available. First is SSG, that is split skin graft. Thias grafts are cultured skin. Synthetic dressing available like hydrocolloid dressing. BioBrain is a collagen which is easily available and commonly used for a small burns. And biologic dressings are xenograft, they are available from a pig skin, and allograft. Allograft is from the cadaveric skin. Cadaveric skin transplant also done for maintenance of an emergency for first 7 days. And this is a general principle of management: water tapping, occlusive dressing, exposure method, topical antibiotics, then hydrochloride dressing, biojet dressing, and sterotomy. These are the mainstay of the management. And healing occurs slowly. It is a collagen dressing, deep dermal with excision. Topical adrenaline will reduce the bleeding. All whenever there is a blood loss in tangential excision, sterotomy causes a severe bleeding. So adrenaline must be used whenever there is a bleeding occurring after 6 to 8 days. Usually when you remove the scar, bleeding will occur. Topical heparin also reduces edema and pain, so it is commonly used in children. After that, in the late stages, it is a delayed reconstruction of burns, that is by plastic surgeon, flaps, Z-plasty, hypertrophy is reduced by pressure bandage. Itching is a major complaint of a burn post-operatively, first and second degree, particularly second deep. Severe scarring, severe itching. For that, you have to treat the itching with the help of corticosteroids or local agents. Nutrition has to be taken care. These are always a hypercatabolic state, so their requirement of nutrition is more than normal. This can either be given in early days by a nasogastric tube or by a total parental nutrition. So this is we have considered regarding the thermal type of burn injuries. Most common, but second most common which we come across also, it is a electrical burns. Many times question are regarding only electrical burns is asked. That is why we are giving some more time to the electrical burns. Here you have to understand the pathophysiology. Electrical injuries are of two types. First is low tension injury, high tension injury. Patient gives history that he had touched the high tension line. What is the difference? Low tension less than 1000 volt. high tension more than 1000 volts, and intense damage to the tissue about 2000 degrees centigrade. Imagine the temperature and what the patient must be feeling. This is the same temperature which is achieved whenever there is electrocution. During rainy season, whenever electrocution and death occurs, 2000 degrees centigrade is the temperature, and it is always a major burn. For a low tension injury, there is a wound of entry and wound of exit. It is very important. This is important for entry is small and exit wound is very large. Because of this entry and exit, patient can have internal organ injuries like gastrointestinal tract, thoracic. Brain injuries can give convulsions and constant or instant death due to ventricular fibrillation, because all electrical burns cause cardiac arrhythmias. And even if patient survives, unfortunately he is likely to develop gas gangrene. And this, because of a myoglobin release, these people will go, or this patient will go to renal failure. Biochemically, acidosis is very common. Patient should always be admitted to a burn unit and assessment done by ECG. This is a major indication for admitting the patient. All investigations like cardiac monitor, chest X-ray, CT, brain scan are also required. The treatment depends on injury and is managed accordingly. Fracture dislocation, then it is mannitol. Mannitol is a drug of choice here because this prevents the renal failure by prevention of a myoglobin. Surgical management, early ischiotomy. This is most important to prevent amputation. Early means immediately. First remember, this is a deep burn and there is no pain. Even if you cut the whole skin, patient will have no pain. So it should be done in OPD. Excise the wound, surgery of the internal organ, SOS amputation, and cardiac monitoring. So this is regarding the electrical burn monitoring chart. High voltage can cause ventricular fibrillation, cardiac arrest, death, extensive organ injury. Low voltage, deep burn at the site of entry. And remember, burn is not a one-time process, it is a slow burn. The area of burn death can be deeper and deeper up to 8 days. Never take a small entry wound lightly. What is the management? Emergency resuscitation, assessment of burn, prevent renal failure, fasciotomy, debridement, and reconstruction if possible. Complications: neurological, cardiac, vascular, ischemia, contractures, pneumonia, abdominal problems, bone and joint injuries, and cataract can occur in all burn patients. And more important is compartment syndrome. So for compartment syndrome, ischiotomy is the only answer. How do you manage it? Monitor ECG, CT, and all the renal function tests, because myoglobin will affect kidneys. How do you prevent? You have to take extra care whenever you are dealing with any electrical work. And electrical system in your home should be always examined. Okay, this is the prevention. And this is the latest. As per the ATLS, that means Advanced Trauma Life Support 10th edition, they have changed the burn formula for first and second degree burns. What they say? Our original formula says 4 ml. 4 ml for any age group. What they are doing? Above 14 years of age, it is 2 ml of a ringer lactate, not 4 ml. Urine output has to be maintained at 0.5 ml per kg. That means don't overhydrate them. 0.5 ml per kg is satisfactory. Below 14 years, it is 3 ml of RL per kg. And urine output 1 ml per kg per hour. Electrical injury of all ages. Electrical injury has been given more weightage. Here we are giving 4 ml of ringer lactate and you have to have urine output in the range of 1 to 1.5 RV. That means almost normal output is expected. Why these all things have come? Because what has happened? There is an over-enthusiastic management by giving IV fluid to burn patient, and that has led to many times pulmonary edema and ARDS. So it was later on realized that giving so much of IV fluid is not essential. You can depend on the age and the type of burn. So remember, this type of change has occurred into the burn management. So in short, we have considered all aspects of a burn management. This is like a revision of a burn patient, a revision of a burn management regarding depth, the formulas, the fluid formulas, the calculation formulas, and the management. Okay, next question. So we are going to next question. This is describe the causes, clinical features, investigations, and management of acute ischemia of a lower limb. You will just question what is acute ischemia. We have been considering the TO for a long time. Whenever we go for arterial system, we always talk of a TAO or atherosclerosis. What is the difference? That is chronic limb ischemia, CLI, and this is ALI. This is acute limb ischemia. Remember the difference. Acute limb ischemia is caused by acute reduction or stoppage of blood supply to lower extremity. Very common in lower extremity. Acute limb ischemia, ALI. The causes are totally different. Remember, you must know this. Embolism from a prolonged bedridden or a cardiac disease patients. Whenever these patients, either a bedridden ICU patient or a cardiac patient, gets a severe leg pain, cold and clammy extremity, goes in favor of a embolism. Second cause, inadvertent use of a tourniquet for a prolonged use. Third cause, thrombus formation, blocking of a thrombus in atherosclerosis. Equally important, trauma. Trauma can be due to direct injury to artery by a penetrating bone or any penetrating object. Indirect trauma due to compartment syndrome, that is a post-traumatic compartment syndrome, can cause acute limb ischemia. And fourth is critical limb ischemia, where smoking is a major cause. So what indicates critical ischemia or acute going into critical? Ankle brachial index less than 0.5. Okay, so CLI is characterized by rest pain, ulcer and gangrene, and ALI is characterized by the acuity, the sudden reduction in blood supply. And here the symptoms do not have any relief up to 6 hours or the treatment is done. Okay, in chronic you will have a symptom at rest, ulcers and lesions will be there. In acute, nothing like that. Within 6 hours treatment has to be done or we may land in some major problem. This is ALI, acute limb ischemia. So what are the clinical features? We have considered causes like main causes emboli because of a trauma or a thrombus because of a chronic occlusion. Suddenly having a large embolus. Embolic arterial occlusion is an emergency which requires immediate treatment. Chronic limb ischemia, you have time. ALI, no time. Ischemia beyond 6 hours is usually irreversible and results in limb loss. The leg is most commonly affected, and what 4-5 P's: pain, pallor, paralysis, loss of pulsations and paresthesia. So these are the signs of a acute limb ischemia. Cold is, limb is very cold and toes cannot be moved. The diagnosis can be made clinically whenever the patient without history of claudication and who has a source of emboli like a cardiac embolization or long-standing calf muscles. That means the emboli from calf also equally common cause. Who suddenly develops severe pain and numbness of limb which becomes cold and mottled is the diagnostic of ALI. Movement progressively difficult, and there you can have a similar picture whenever there is a brachial embolus in the arm also. That means this embolization can equally occur in upper extremity. So pain, pallor, paralysis, pulselessness, paresthesia. Acute occlusion due to embolus differs from occlusion due to thrombosis on pre-existing atheroma. What is the difference? Whenever there is a previous atherosclerosis, patient is likely to have developed collateral circulation over time. So we have to understand the difference. If there is a collateral, patient stand a better chance of a limb survival. What investigations? Very common. Segmental pressure measurement, blood test, Doppler, angiography, CT angio or MR angio, USG abdomen, treadmill, plethysmography, AB index, Brown's vasomotor index, and transcutaneous oximetry. These are all investigations which are required. Among them, Doppler, which can routinely do, and angiography is important for management of and diagnosis and management, where by angiography you can go for removal of a thrombus. Okay, this is diagnostic plus curative. So treatment, till you have time, it is always important to give heparin. Heparin 5000 units IV or by subcutaneous route must be given whenever you are doubting a thrombus or emboli. Second is surgical management is embolectomy. Non-surgical management is thrombolysis. Okay, so embolectomy is done by nowadays all physicians, and thrombolysis is not so severe. If you have got time, thrombolysis can be done. And if there is a compartment syndrome, you have to go for opening of the compartment. This is urgent compartment fasciotomy to release the compression. And where it is done, the most common site for fasciotomy is the calf muscle. Okay, for acute lower leg ischemia. Now, what is the plan? The routine plan for all arterial diseases: stop smoking, exercises, control walk and diet, control hypertension, control diabetes, control anti-drug like atorvastatin or pravastatin, clopidogrel, cilostazanol. Mainly we have considered this drug for the Buerger disease, and PTA, percutaneous transilluminal balloon angioplasty, is the treatment of choice for all types of embolism, and amputation as a last resort if the gangrene is established or spreading. This is how the management of the acute limb ischemia goes. The next question is also very commonly asked. This is the causes, clinical feature, diagnosis and management of a gastric outlet obstruction. From a general surgery, we are going to systemic surgery. Okay, but this is revision. We have to have everything. What is a gastric outlet obstruction? GOO. Remember, gastric outlet obstruction is GOO. Commonest cause. There are two most common causes. The most common cause is pyloric stenosis secondary to peptic ulceration. And second common cause is gastric cancer near the pyloric region. So two common cause, ulcer and gastric cancer. Remember only this one. Now if you remember this chart from Love and Bailey, you can write a full question. So go into details of this. Gastric outlet obstruction. Most commonly associated with a long-standing peptic ulcer disease and gastric cancer, the etiology. Pathology. The metabolic abnormality of a hypochloremic alkalosis. You see here, the chlorines are lost. Hypochloremic alkalosis because of vomiting is usually seen in peptic ulcer disease and should be treated with isotonic saline and potassium. In cases of a carcinoma stomach, this type of hypochloremic acidosis, alkalosis is less seen. Treatment or diagnosis, endoscopic biopsy. In all these cases, endoscopic biopsy is essential to determine whether the cause of the problem is malignancy or simply peptic ulcer, because management changes. Aggressive medical therapy for peptic ulcer disease may lead to resolution of the symptom. Non-surgical management, endoscopic dilatation of a gastric outlet can be effective in comparatively early cases or less severe cases. We have code management also. Last management, operation. What is surgical management? Frankly, it is very less required. What is surgical done? Is a drainage procedure. All benign diseases, drainage procedure is done, and for all malignancy, it is a resectional surgery. So in these 5 or 6 lines, we have finished gastric outlet obstruction as a full question. Remember this basic for GOO. So understanding it, what are the clinical features? Long history of a peptic ulcer disease. Most patients of peptic ulcer are treated symptomatically or medically. That gives a long history. In some patients, pain may be unremitting, unreliable, severe pain. What are the characteristics of a GO? Vomitus. Vomitus is characteristically unpleasant odor. One cannot stand by the side of patient, and the vomitus does not contain bile. The color of the vomitus itself shows whether it is from the duodenum or it is from the stomach. That means infraduodenal, supraduodenal. Few of the patients 2 or 3 days old foodstuff can be seen. That means food is not going below the pylorus. These patients are usually unwell, dehydrated and weight loss. In this patient, the clinical sign is distended stomach and succussion splash. What is it? By stethoscope, you can listen to the sound of stomach and water and air moving into stomach on you whenever you shake the abdomen. This is called as succussion splash. Metabolic effects like there can be hypochloric acid results in hypochloremic alkalosis. Urine is paradoxically acidic. Even if there is no acid, urine is acidic. There are different causes. And hypokalemia. Why hypokalemia? Because alkalosis leads to lowering of circulating ionized calcium, and the result in clinical features, patient vomiting continuously, fullness of abdomen with tetany. If the patient has a feature of tetany, it goes in favor of a GOO. There are electrolyte changes like hyponatremia, hypokalemia, metabolic alkalosis and paradoxical aciduria. Simply remember hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia, everything less. The presentation for us is a tetany. Okay. What are the investigations? They are very simple. Commonest investigation done in past was a barium meal study. In barium, you can find that absence of a duodenal cap. If you see in the figure, the duodenal cap is not well formed. Dilated stomach, most important. Dilated stomach, how do you define? The greater curvature is below the iliac crest. This simply by the figure you can see it is far below. This goes in favor of this GOO. Stomach is mottled and gastroscopy is always required to rule out carcinoma. You have to go for electrolyte studies, ECG and all other electrolyte investigations. How do you differentiate? So differential diagnosis is pyloric stenosis and carcinoma pylorus. These are the two main diagnoses. For a pyloric stenosis, it can be congenital, it can be chronic DU, it can be carcinoma of the pylorus, or it can be adult pyloric stenosis, where the treatment is by pyloroplasty, not by pylomyotomy, pyloroplasty. You have to differentiate, okay? So, how are you going to manage? The mainstay of a gastric outlet obstruction is emptying of the stomach. This is life-saving. How it is done? Either by a nasogastric tube, but commonly wide bore gastric tube is required. This is important to empty the stomach and give the chance for the lavage. Unless you have to wash the stomach thoroughly with normal saline. Without that, all investigations cannot be possible. Rehydration of patient with normal saline, then isotopic saline and potassium. Replacement of sodium chloride and water. Whenever there is anemia, blood. All cases which are very early can be settled with conservative treatment. In severe cases, it is surgery. In advanced center, it is endoscopic balloon dilatation. And more advanced center, duodenal stent insertion. So these are the management part. So continuation, correction of dehydration, electrolyte balance, blood transfusion, total parenteral nutrition may be required because this is a chronic condition. Stomach wash is a must, and surgery, the type of surgery done is HSV. HSV stands for high selective vagotomy with gastrojejunostomy. This is a common done because it is not very difficult. HSV is difficult, but gastrojejunostomy is not difficult. But HSV is better than total vagotomy because it maintains nerve supply to the antrum end. So eventually it will reduce chronic emptying problem. Commonly done truncal vagotomy, that means total vagotomy with GJ. It is an ideal and commonly advocated. And this is how surgical management. It is always Billroth 1 if the patient is late. So we have considered the different parts of the gastric outlet obstruction. Clinical features, causes, differential diagnosis and management, medical management and surgical management. This brings to the end of a gastric outlet obstruction. Now this question is also asked. This is a simple question but commonly neglected. What is this? Write classification, clinical features, staging and management of testicular tumors. Very simple question. How do you write it? First try to understand what the testicular tumor means to us. There are two types of testicular tumors. 95% are called as GCT, that is germ cell tumor. Remaining 5% are non-germinal neoplasm. GCT 95%, non-GCT 5%. And they include all different types like Leydig cell tumor, Sertoli tumor and gonadoblastoma. This occurs comparatively at a younger age. So what is the classification? According to WHO classification, 2. Germ cell tumors. Germ cell tumor and non-germ cell tumor. Germ cell tumor comprise of seminoma. They are typically anaplastic and spermatocytic. Next is embryonal cell carcinoma, yolk sac tumor, choriocarcinoma, teratoma and carcinoma in situ. Remember only two, seminoma and teratoma, both are germ cell tumors. Simple. Non-germ cell tumor, common are Sertoli tumors and arising from Leydig cell. These are the mixed type, the non-germ cell tumor. Few of them has got germ cell plus sex cord element. They are called as gonadoblastoma or mixed tumors. There can be lymphoid tumors. Lymphoid and hematopoietic, lymphoma, plasmacytoma, leukemia. About lymphoma, lymphoma is the commonest tumor of a testis occurring in old age. Only remember this much, you are through. So, germ cell tumor, non-germ cell tumor. In germ cell, seminoma and teratoma. Non-germ cells, Sertoli tumor, Leydig tumor. Germ cell, two types, seminoma, very important, more than 50%, it has got a better prognosis. Non-seminoma, teratoma, choriocarcinoma, yolk sac. They are usually common above 50 years is lymphoma. Seminoma tumors are better, they are more friendly, better prognosis. Non-seminoma tumors are more malignant. So this is regarding the classification of a testicular tumor. Okay. Now we go to the factors. What is the causative agents? Commonest causative agent for seminoma is cryptorchidism. This is undescended testis. Testicular feminizing syndrome. This is genetic syndrome. And GCT. GCT stands for this germ cell tumor. Germ cell tumor occurring in one testis has got a 100% risk of other testes developing GCT. Whenever testicular tumor is occurring in a sibling, that means a brother, patient stands or other brother stands chances of developing tumor. Whenever estrogen is administered to the mother during pregnancy, this also increases chances of a GCT in adult. So seminoma 50% GCT. Seminomas follow indolent course and they are more common above 40 years. Non-seminomas usually third decade. Seminomas above fourth to fifth decade. What are the stages of seminoma? Stage 1 confined to testis, more than 70%. Stage 2 testis plus retroperitoneal metastasis, 20%. Stage 3 whenever it is spreading beyond retroperitoneum, it is 10%. So it is metastatic grade 3. And remember, seminomas metastasize through the lymphatics. And most important, seminomas are most sensitive, radiosensitive tumors. You should never forget. Seminoma, surgery plus radiotherapy. Non-seminomas, they are insensitive to radiotherapy. So management, surgery plus massive lymph node dissection. For a diagnosis, you can go for tumor markers like beta HCG, AFP, LDH, and remember, seminoma is commonest tumor in cryptorchid testes. What are the clinical features? Simply, commonest is enlargement of testes. Patient complains of fullness or heaviness in the scrotum because of increase in size. Testicular pain is comparatively less. It is in 30% of patients. Enlarged, firm, heavy testes. Heavy. See the difference. If it is hydrocele, the testes is light. If it is malignancy, testes are heavy. This differentiation you can do only clinically. And loss of testicular sensation. Whenever you grab the testis, there is a very typical sensation, and that sensation is lost. All early diagnosis, if there is no testicular sensation to enlarged testis, you must always consider malignancy. The malignancy is also one of the cause of a secondary hydrocele. In those patients, the cremaster is hypertrophied and thick, but there is no involvement of a vas or prostate or seminal because they are not lymphatic drainage. Other non-lymphatic drainage is hemoptysis, bone pain, and sometimes it may mimic acute lipedema orchitis when there is pain or acute hematocele. So these are the differential diagnoses. In few of the patients of teratoma, patient may have a gynecomastia. So gynecomastia can be seen in cases of a teratoma, not in seminoma. Why? Because it is due to raised HCG hormone. So diagnostic for carcinoma or testis is hemic scrotum with absence of rugae with suspicious mass in the groin suggests undescended testis with a testicular tumor. So any mass in a groin with absent hemiscrotum is in favor of a carcinoma of the testicular tumor. This you must remember. Unfortunately, 3% of testicular tumors can be piloted. Inguinal nodes are involved whenever the tumor is breaching the tunica albuginea. This is a covering layer and it can spread to scrotum in very late stages. Very late few cases, CNS and spinal cord. But usually one type of malignancy which is called as a hurricane type of a testicular tumor is highly malignant testicular tumor which is more often fatal in few weeks. Okay, then non-germ cell tumors, Leydig cell tumor. This Leydig cell tumor is a muscularizing tumor of a testis. This occurs usually in a very young age. So it is a pre-pubertal tumor. Before puberty, what it shows? Excessive output of androgen. This causes sexual precocity, extreme muscular development, and which mimics what is called as a infant Hercules. Infant Hercules is seen in case of a Leydig cell tumor. But they are relatively benign and can be treated by surgery only. They are radio resistant and chemo resistant. Surgery is the only answer for a Leydig cell tumor, musculizing. Another is Sertoli cell tumor, which is feminizing. Post-pubertal, here the patient has got a feminizing effect like gynecomastia, loss of libido, and aspermia. This is a Sertoli cancer tumor of a disease causes aspermia. And in all these cases, surgery is the treatment of choice. Okay. Coming to the spread. How does it spread? Local spread, spreading to epidermis, cord, tunica albuginea, scrotum, and so going to inguinal lymph node. Lymphatic spread, para-aortic and retroperitoneal. Right testicular, aortocaval, left testicular, para-aortic. Seminoma spreads to lymphatic more than teratoma. Extranodal goes to lung, liver, brain. So this, just remember, staging of a testicular tumor. The simplest diagnosis, simplest form. 1. Lesion confined to testes. 2. Nodes involvement below the diaphragm. 3. Node involved above the diaphragm. 4. Distant or blood spread. This is the staging of a testicular tumor. Simplest definition. Remember this. Okay. So how do you investigate and manage? For investigations, the thumb rule is no FNAC, no scrotal approach, no incision biopsy. Okay. You have to make diagnosis regarding the clinical impression and USG. No FNAC, no scrotal opening and no incision. So what should we do? There is a manual. Whenever you want to diagnose it, it is a Chevasu's manual. It has come as a short note. What it says? Through a inguinal approach, testes and cord is exposed. Through inguinal. What are you doing? Apply a soft clamp to the cord at the deep ring so that you prevent dissemination through blood. Frozen section biopsy is done from a suspected area, and if it is positive, we should be prepared for high arcadectomy. Okay, so this is the approach. This frozen section biopsy by a inguinal approach, Chevasu's manual. What are we going to measure? Tumor markers, chest X-ray, USG abdomen, USG scrotum. This is important to see the echogenicity of testes and how the tumor is looking. CT abdomen, CT chest. So these are the investigation of a testicular malignancy. Treatment is very simple. It is always archaeectomy first. All archaeectomy should be done at high archaeectomy. The difference in treatment lies in after high archaeectomy, radiotherapy is given as a cure and to reduce relapse in case of seminoma. This seminoma is radiosensitive, and in early stages it is a treatment of choice in stage 1 seminomas. Remember, you may not go for surgery if you diagnose it as earliest. During radiotherapy, you have to shield opposite testes because opposite testes can develop malignancy due to radiotherapy. Seminomas with high level of tumor marker are treated as a non-seminomatous tumor. That means higher decision, you have to go for retroperitoneal resection. Chemotherapy, cisplatin is a drug. Another malignancy is teratoma. Teratomas are radio-resistant tumors. Seminoma radiosensitive, teratoma radioresistant. So what done surgery? After the excision of a high archaeectomy testicular retroperitoneal radical lymph node dissection. This is called as RPLND. Is most beneficial after high archaeectomy. This is done even in 1, 2, 3, 4 stages. So RPNLO is a major role in case of teratoma. This book picture shows where exactly you are going to ligate the cord or the vas in the high archaeectomy. In cord you have shown 3 figures. This is the inguinal incision where you are ligating or clamping the cord at or near to the internal ring. Okay, so we are coming to the end of the management of malignancies of testes. Common is seminoma, another is teratoma. Testes are most common in cryptorchids. So this is indifferent. Seminoma radiosensitive, teratoma radioresistance. Investigation of choice is only Chevreul's maneuver. You have to see clinically. The weight of testes, loss of sensation goes in favor of a malignancy. There can be masculine or feminine tumors. If you write down this much, I think you have got a good knowledge and you will have flying color. So we come to the end of our 2014 question paper. Thank you very much for your patient hearing. Good day.